called the diazepam. It is the oxazepam which is preferred in case of the patients who are having any altered liver enzymes. So next, moving on to the which is the most effective drug which is used for smoking cessation or chronic smoker who wants to stop smoking, which is the drug which is preferred. So please remember, you can use nicotine also, buprenorphine also, but not neostigmine, but not atropine, but you can use vernaculine. So among this, which is the most preferred? First preference should be given to vernaculine. Vernaculine is the most effective drug in the smoking cessation, which is the alpha 4 beta 2 nicotinic receptor selective partial agonist, which will going to decrease the dopamine release. Buprenorphine is a atypical antidepressants. You can use nicotine patches, nicotine gums, nicotine inhalers, nicotine nasal spray, nicotine lozenges. So these can be used, but preferred is the vernaculine. If all these options are given, you need to go with the vernaculine. Apart from that, you can also use tricyclic antidepressants as well as the clonidine for smoking cessation. Next, moving on to the next question, that is 45-year-old male not on any medication, now diagnosed with diabetes, hypertension with grade 5 chronic kidney disease with high serum urea and creatinine. Patient does not wish to take insulin. So what drug is most suitable or preferable to this patient? So please remember, if the patient is not willing to take a insulin, so the preferred drug in case of hypertensive diabetic individual who are having any kidney dysfunction, you can go with the DPP 4 inhibitors, especially the Linagliptin. So Linagliptin, it will be bound to plasma protein and it will be excreted through the hepatobiliary system. So clearance is mainly through the hepatobiliary system, and it has got low renal clearance. That's why it is preferred in case of kidney dysfunctions. Whereas you cannot use allogliptin, saxagliptin, vildagliptin, as well as the sitagliptin. Why they are not used here? Since all these drugs will be cleared mainly through renal system. So clearance is mainly through the renal system. So we cannot use the exenatide also, since it is to be given through subcutaneous route, which is a GLP-1 analog. Glimepiride is a sulfonyl urea, and Acarbaose is the 5-alpha reductase inhibitor. So the preferred drug in case of chronic kidney disease is the Linagliptin. Next, coming to the rituximab. Rituximab is which of this is the action of rituximab? Option A, anti-CD20 polyclonal, option B, anti-CD20 monoclonal, C, anti-CD50 polyclonal, and D, anti-CD50 monoclonal. So here the answer will be, it is the anti-CD20 monoclonal antibody. Please remember, there are three more drugs under anti-CD20 monoclonal antibody. Apart from rituximab, you have a ofatumumab, and also you have a obinutuzumab. So these three are the anti-CD20 monoclonal antibody. So remember, rituximab, ofatumumab, obinutuzumab are the anti-CD20 monoclonal antibody. So where do we use rituximab? Basically, we use rituximab in case of the non-Hodgkin's lymphoma, including CLL. It can be used in the treatment of the idiopathic thrombocytopenic purpura. It can be used in case of IBD. It can be used in case of rheumatoid arthritis. It can be used in the treatment of systemic lupus erythematosus. It can be used in the treatment of autoimmune hemolytic anemia. It can be used in the treatment of multiple sclerosis. So these are the uses of rituximab. Next, moving on to a patient with glucose 6-phosphate deficiency. Which of the following drugs precipitate hemolysis? So please remember, even the chloroquine can precipitate hemolysis in glucose 6-phosphate deficiency individuals, but not the penicillin as well as the tetracycline. So primaquine can lead to hemolysis in case of glucose 6-phosphate deficient individuals. So please remember, the order of severity of hemolysis will be primaquine followed by chloroquine followed by quinine. So here the answer will be primaquine. So there is a mnemonic to remember, which are all the drugs which are causing the hemolysis in case of individuals who are having glucose 6-phosphate deficiency. The mnemonic is prima, sad, peg, taqui, cola. So P stands for primaquine. M stands for mefenide, which is a sulfonamides. Then the S stands for, again, sulfasalazine. A stands for aspirin. D stands for dapsone. T stands for tafenoquine. Q stands for quinine, and C stands for chloroquine. So this is the mnemonic you can remember for the drugs which are causing hemolysis if the individuals are having the glucose 6-phosphate deficiency if they are administered. So coming to the next question. So this was the question which was asked, and we could not recollect the options. So please remember, Artesunate and sulphodoxime pyrimethamine combination is given in the treatment of malaria. So next question, which of the following statement are true about anti-tubercular drugs? So let us see the options. So the isoniazid inhibit mycolic acid synthesis. So this is the right statement. Pyrazinamide is an inducer of CYP450 enzyme. So this is not the right statement. And rifampicin is not useful in any other disease. So this is the wrong statement. Rifampicin can be used in many other conditions. So let us see after this. So which are all the conditions where you can use rifampicin? So BIDAC will inhibit mycobacterial ATP synthase. Yes, this is the right answer. So the answer will be, correct statement will be the option 1 and option 4. So what are all the conditions where you can use rifampicin? The mnemonic you can remember is the burn, fern, lamp, and os. Burn for brucellosis, fern for Furunculosis, L for leprosy, A is for ATT, anti-tubercular drugs, and M stands for meningococcal carrier states. P stands for prosthetic valve, endocarditis, and the OS stands for osteomyelitis. So these are all the conditions where you can use rifampicin. So next, moving on to the next question, which of the following anti-glaucoma drugs can increase the trabecular outflow predominantly? So let us see the three different action through which the glaucoma can be treated through the drugs. So first one is the drugs which are decreasing the aqueous humor. So which are the drugs which are decreasing the aqueous humor? You have mnemonic A, B, C. So the alpha agonist, B for beta blockers, C for carbonic anhydrase inhibitors. So here alpha agonists can be apraclonidine, brimonidine, beta blockers, timolol, butoxolol, carbonic anhydrase inhibitors like astazolamide, brinzolamide, dorzolamide, etc. And which are the drugs which will increase uveoscleral outflow? You can remember it as AP. A stands for the alpha agonist. P stands for the prostaglandin analogs. So which are the drugs which will going to predominantly increase the trabecular outflow? Can remember it as ramp. So R stands for rho kinase inhibitor. A stands for again the alpha agonist. M stands for miotics. P stands for prostaglandin analogs. But these action, alpha agonist action, is with respect to increased trabecular outflow will be the minor action, but major action will be the decrease in the aqueous humor. So here the novel drugs which can increase the trabecular outflow will be rho kinase inhibitor, that is netersudil. Here the correct option is netersudil. So it is not the astazolamide, it is not the brimonidine, it is not the timolol. Although brimonidine has got minor effect, but netar-sudil has got major effect on the trabecular outflow, where these netar-sudil will going to inhibit the Rho kinase. Rho kinase is responsible for what is Rho kinase is responsible for? Rho kinase is responsible for increasing the strength of trabecular meshwork. So by inhibiting, you are going to reduce this trabecular meshwork strength. Thereby, you can increase the aqueous humor outflow through the trabecular outflow system. Thereby, you can reduce the intraocular pressure. So the correct option here is the netar-sudil. So next, coming to which is a beta 2 agonist. But when we see these options, so dapivirine is basically a alpha agonist. Phenol dopa, it is D1 and alpha 2 agonist. Mirabegron, it is the beta 3 agonist, and dapaxamine is the D1, D2 and beta 2 agonist. So probably this question could be, which is the beta agonist, which are all the drugs which can act on beta receptor. In such case, even the dapivirine, which is a derivative of the adrenaline, dapivirine will be converted into adrenaline. So adrenaline can act on beta receptors. In such case, the option A, option C and the option D will be the right answer. That means 1, 3 and 4 will be the right answer. 1, 3 and 4. So these are the drugs which can act on beta receptor. They act in the form of activating the beta receptor, beta agonistic activity. So dapivirine is usually used in the treatment of glaucoma. Phenoldiazepam is used in the treatment of hypertensive emergency. Merberon in case of overactive bladder, that is in case of incontinence, and dapaxamine is used in the treatment of CHF. So coming to the next question, oxcarbazepine is better tolerated than carbamazepine except. So this is the anti-epileptic drugs. So carbamazepine causes more of rashes, GI disturbances and hepatotoxicity, whereas these three side effects are more seen with the carbamazepine, and oxcarbazepine will lead to more of dilutional hyponatremia. So the answer is dilutional hyponatremia. So this is the option D is the answer. So new drug application is done after which phase of clinical trial? So please remember, initially whenever a drug is taken into the trials, so we will do the preclinical test where it will be done on animals, So once you detect that these test drug will be beneficial, so this will be selected for clinical trials in humans. So before taking to the clinical trials, there will be application. That application is called as investigational new drug application. So in the clinical trial, there will be phase 0, phase 1, phase 2, phase 3 and the phase 4. So phase 0 is also called as microdosing. So what will happen in case of microdosing is, initially 10 to 15 healthy volunteer will be taken, and you will use 1/100 dose of the test compound, and you will mainly going to evaluate the pharmacokinetic profile. If the pharmacokinetic profile sounds promising, 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 it will be taken to phase 1. So if it is not promising drug, it will be further step will be stopped. So if it is promising, it will taken to phase 1, where again in the phase 1 very minimal number of healthy volunteers will be taken. Healthy volunteers will be taken mainly to check for the pharmacokinetic profile and the safety. Next, after the pharmacokinetic profile and safety is proven, it will be taken to phase 2. Phase 2 is done at single centers, but it will be on the patients. So it will be range from 50 to around 100 to, and remember, 50 to 500. In phase 3, it will be done on more number of patients. Can take 500 till 5000. So this will be the multi-centric study. It will be done at different hospitals on the patients. So here in phase 2, it is called as therapeutic exploratory phase, and this is called as phase 3 is called as therapeutic confirmatory stage. So once you confirm that this drug is benefiting the larger group of population, then it will be marketed. That is phase 4. And in the marketing, you will be seeing the pharmacovigilance. Under pharmacovigilance, you are going to evaluate the rare adverse effects or adverse effects which were not seen during the clinical trial. That is post-marketing surveillance. So before coming to the market, the agency which is testing will be applying to the regulatory agency. So that application will be the new drug application. So here the new drug application is done after which phase of clinical trial? It is done after phase 3. So the right answer is phase 3. So which class of antiarrhythmic drugs are this? So according to the recall, the option given was So if you consider it as we'll draw a 3 diagrams. Okay. So if the diagram was like this, let us see another diagram. Okay. The third diagram goes like this. Okay. This diagram depicts the voltage versus the time. So this graph is the representation of class 1A antiarrhythmic. This is class 1B antiarrhythmic. This is class 1C antiarrhythmic. So here you can see that these has got moderate sodium channel blockade, and this has got weak sodium channel blockade, and this class C has got strong sodium channel blockade. Apart from that, they also block the potassium channels, class 1A. and sometimes the class 1C will also block beta receptors. So when we take the action potential duration and the effective refractory period, so this will be increased. So this will be increased in case of class 1A, and see here you can see the effective refractory period has been increased. So you should count from dotted lines till to this line, and here you can see the refractory period has been, action potential has been decreased. Here the action potential is not affected, no effect. What is the example here? Here it is quinidine, here lignocaine, here it is flecainide, propafenone, mexiletin, etc. And again you can have procainamide. So all this belongs to class 1 antiarrhythmics. So you can choose the appropriate answer based on the diagram which they are asked in your exams. If they asked about these graphs, the answer will be the one. If they asked about class 1B, if they had given these diagram, so the option will be B. If they had given this, option will be 1C. So next question, which drug is used preoperatively to decrease blood loss during thyroid surgeries? So propylthiouracil and methimazole, they are the thyroid peroxidase inhibitor, and propranolol will going to decrease the sympathetic activity in case of hyperthyroidism as well as in case of thyrotoxicosis. So it is the potassium iodide which will be given preoperatively to shrink the gland. So basically it is given to shrink the gland. So shrinking of gland can be done by decreasing the blood supply to that gland. Therefore the advantage is bloodless field of surgery, and the shrink gland can be easily identified and removed. Apart from that, you can also use sodium iodide, also Lugol's iodine. Lugol's iodine consists of potassium iodide 10% and the iodine 5%. Next, moving on to the drugs which are used in dyslipidemia, which causes gallstones. So please remember, it is the peroxisome proliferator activated receptor alpha agonist. Those are nothing but the fibrates like clofibrate. So these clofibrate are more prone for causing gallstones, whereas statin will cause myopathy, myositis, etc. Niacin will going to increase the risk of diabetes. It can increase the uric acid production, flushing and itching. Whereas bile acid sequestrant, the most common side effect will be the constipation. So the answer for this question will be the peroxisome proliferator activated receptor alpha agonist. So apart from this, there are some drugs which can also cause gallstones, that is the octreotide, and also there is two drugs which specifically causes gallstone from the anti-epileptic drugs. You should remember two drugs, zonisamide, and next is the topiramate. So these are the two drugs which will going to cause the gallstone from the anti-epileptic drugs. Anti-epileptic drugs. So next, moving on to the next question. So the mechanism of action of the aspirin as an antiplatelet drug. So the mechanism of action is antiplatelet action by the aspirin is it blocks or inhibit the thromboxane A2 activity. Thromboxane A2 activity. So what are the example for the GP2B 3A inhibitor? You have three drugs: abciximab, heptifibatide. Then you have a tirofiban. So abciximab, heptifibatide, tirofiban, they belongs to GP2B3A inhibitors. P2Y12 inhibitors, example are prasugrel and clopidogrel. Next, coming to the patient has got hyperkalemia. Please remember, patient has got hyperkalemia, and which of the drugs to be stopped here? So these are the options which were given: furosemide, amlodipine, losartan, and the metoprolol. Please remember, furosemide will going to cause hypokalemia. Amlodipine will going to cause hypokalemia. Here, the main drug you should remember, the direct answer is the losartan. Losartan will cause hyperkalemia. Although the metoprolol will also cause hyperkalemia, the extent of hyperkalemia caused by losartan will be more. Losartan will be the more. So we need to find whether this option was present or not. If the salbutamol was present, salbutamol, which is a beta 2 agonist, it will cause hypokalemia. So how to remember the mnemonic? So we can remember the mnemonic in the form of captopril. Captopril. C stands for cough, dry cough. This is the side effects caused by ACE inhibitors. A stands for angioedema. P stands for potassium levels are increased. That is hyperkalemia. T stands for teratogenic effect. O stands for others. It can cause headache, nausea, etc. It can cause orthostatic hypotension. Captopril. P stands for proteinuria. R stands for renal insufficiency. So I stands for it can lead to itching, and L stands for low blood pressure. Apart from this, you should also remember that these drugs can cause cholestasis, as well as taste alteration, that is dysgeusia. So these are all the side effects which are encountered with the ACE inhibitors. Next, moving on to the next question, that is patient on losartan, now diagnosed with the HbA1c 8 grams. What is the alternative drugs to losartan? Please remember, if the patient requires the alternative drug to losartan, which will going to help the diabetic individuals in controlling their or regulating their blood sugar levels, you need to remember 3 drugs, that is still. So ARBs, which are having peroxisome proliferator activated receptor gamma activity. They are TIL. T stands for telmisartan. I stands for